Hey everybody, and welcome to our talk about hematology. We will be talking primarily about red blood cells today, and I hope you find the information useful. So, hematology problems are classified as red blood cell, white blood cell, platelet, or coag functions. And so, these are the things that we will talk briefly about. We're primarily going to focus on red blood cell function today. Red blood cells are erythrocytes. Erythrocytes are formed in the bone marrow, in the flat bones, and the proximal ends of the femur and humerus. Erythropoiesis is what we call it when red blood cells are produced. Erythropoietin is the substance made in the kidneys that stimulates the bone marrow to make red blood cells. And the primary function of these red blood cells is to carry oxygen from the lungs and to the tissues. So it makes sense then that a mature red blood cell is mostly hemoglobin to carry oxygen. The hematology system needs an adequate intake of iron for the red blood cells to mature. A red blood cell, once mature, lives about 120 days. B12 and folic acid are also needed. They're needed for the DNA synthesis component of this production. The body has large stores of B12, so it'll take a long time to deplete B12, but it has only very small stores of folic acid, so they deplete very quickly. So folic acid deficiency may be seen a little more frequently as a result. 10% of iron is absorbed in the duodenum and the upper bowel. Iron is stored in the liver, the spleen, and the bone marrow. When it's stored, we call it ferritin. And when it's in the hemoglobin, about 2/3 of it is there. So red blood cell problems, what do they involve? They involve production, maturation, and destruction primarily. Production problems can be acquired or idiopathic. A lot of times this may include blood loss when production is not meeting the demand. It can be idiopathic, meaning us idiots don't know the pathology, as my pharmacology teacher always said. And there can be red cell aplasias, which we will mostly not talk about today. Look at cell maturation, though. This is primarily related to nutrition, maybe an iron deficiency, maybe a toxicity such as lead poisoning. Anemia is the clinical sign of all of these deficiencies of red blood cells, and it results in decreased delivery of oxygen to the cells. The last one there is destruction of the red blood cell, and those are your hemolytic anemias. And the one that we're primarily going to talk about today is sickle cell disease. Anemia is low red blood cell count and below normal hemoglobin or hematocrit level. I gave you some normal labs over there. Look, when you look at hemoglobins and hematocrit, hemoglobin is always about 1/3 of the hematocrit, roughly. Not always exactly, within a point or two. So that's one way to gauge whether you have an accurate result is the hematocrit about 3 times the hemoglobin. Okay. We talked about these causes, and here they are again. Destruction, production, loss for some reason. All of these are related to those we talked about. Now, diagnostic test for anemia. I believe this slide came from ATI, and I will tell you that this is not the first diagnostic test you do for anemia. We'll do a finger stick, we'll do a hemoglobin and hematocrit and a red blood cell count. Usually a complete blood count is included in that. And we'll check for anemia, and we'll try to determine the cause. If no cause can be determined, if it doesn't respond to treatment, then definitively a bone marrow aspirate would be the way to go. Bone marrow aspirates are a little more invasive. They involve putting a pretty large needle into a marrow space, usually the sternum or the iliac crest. It is invasive. It needs an informed consent. Now, it says it's done at bedside. Let me tell you that in children, we don't do these things at the bedside because we want that bed to be a safe haven for them. We do not want there to be any scariness involved. We want them safe in their bed and to feel that way. It is a sterile procedure. It's often done under local anesthesia. Many years ago when I was doing these, we did local anesthesia and we held that child down and talked to them, and we did not do any other um, um, anti-anxiety agents at the time. Now these children are very groggy and don't remember a lot of this procedure. The stylet is introduced. It's pressure as you push through that heavy bone, and then when you aspirate, it's a very sharp, sudden, heavy pain. And finally, we put pressure on it to prevent bleeding. Here's a picture through the skin of the iliac crest, and you can see that needle that is bored in there into these marrow spaces, and then that marrow is withdrawn. It's very thick, very viscous. Here's another picture. You can see kind of how big that needle is. This one has the stylet removed, so it's ready to put a syringe on there and withdraw the bone marrow. For a person with leukemia or a cancer, they may have this done every 3 months. Here's a picture that I believe is a picture of a bone marrow donation. There's a lot of bone marrow being removed. We normally need 5 or 10 cc's to make slides and look under the microscope. This is a lot of bone marrow. And so thinking that this is a bone marrow donation, this bone marrow will be cleaned and processed, put into a bag, and delivered to the recipient by IV. The manifestations include less energy production in all the cells, cell metabolism, reproduction are decreased, compensation mechanisms occur. The primary compensation mechanism that you may see, at least in part, is that the heart speeds up. The heart says, hey, wait, you need blood, I'm going to get you more. Speeds up to meet the need. Vasoconstriction does the same thing. There will be vasoconstriction of the non-essential organs so that the blood with oxygen is shunted to the more necessary parts of the body. General signs here, we're going to keep saying these: fatigue, dizziness, weakness, headache. Think about lack of oxygen, right? Decreased activity intolerance, pallor. Look at the conjunctiva. Look at the mucous membranes. Look at the nail beds, capillary refill. Look around the mouth, circumoral pallor. The lab that we're going to check is the hemoglobin, hematocrit, and red blood cell count. Okay? But think of everything in relation to decreased oxygenation, decreased O2 sats. So nursing management is going to include monitoring those labs, that H&H, the red blood cell count, activity as tolerated with frequent rest. So what that means is that these patients will need a lot of rest, and you will cluster your care so that you don't go in and out bothering them 24 times a day, but that you can cluster care and give them rest periods in between necessary care. Monitor skin integrity. That's really important. They're being still. They're in bed more than they used to be, more than they ought to be. Blood is not getting to tissues. There's a lot of things combined that could increase the risk of breakdown in skin integrity. Oxygen therapy may be needed. Blood products can be used. Blood products may be in the form of packed red blood cells that will help the body get oxygen where it needs to go. So the first anemia we're going to talk about here is iron deficiency anemia, where there is insufficient iron. Without iron, we can't make hemoglobin. Without hemoglobin, the cells do without and can't transport oxygen. Because this is a function of iron, and iron's not there, hemoglobin's not there, the cell doesn't have enough hemoglobin, it is microcytic. Okay, it's small, smaller than usual, and it is hypochromic. So it is pale because it's missing that hemoglobin. Okay. It's pretty common, iron deficiency anemia. It ranges from mild to very severe. It occurs in all age groups. Seems to be more common in women of childbearing years, although we're not quite sure why. It is estimated that 1 in 5 women is affected, and it increases during pregnancy. Oftentimes, it is a sign of an underlying problem, which is why we need to do a little detective work and figure out what's going on. We can treat the anemia, but if we don't fix what's causing it, then it's just going to happen again. Okay? In iron deficiency anemia, there can be a lot of different causes. Bleeding is probably the most common. Rapid growth is another cause, as well as malabsorption. Dietary intake may be low. An example of that is infants. Infants have iron stores initially. They have, when they begin formula feeding, they get iron fortified formula. When they get 4 to 6 months old, they get iron fortified cereal added to their diet. As they begin to eat more people foods and less baby foods, they also start to, around a year old, start to drink whole milk instead of iron fortified formula. And whole milk has no iron. So in that child who drinks an excessive amount of milk, they'll be big and fat and chubby, and they will have iron deficiency. So that's a consideration. A chronic blood loss would be another consideration, from bleeding, from ulcers, even hemorrhoids and cancer. All of those things could be an issue. The absorption may be impaired, and there are quite a few malabsorption syndromes. We're going to talk about one or two. Severe liver disease can also affect iron absorption as well as storage, so you have to consider what disorders include liver disease that may be affected. Most of these things we talked about, let's run through these. Pallor we talked about. Fatigue. Cold intolerance is something that you may or may not have associated with anemia, but they have very low tolerance for cold. Irritability, degenerative changes, stomatitis and glossitis. Excuse me. You may see mouth sores. May see sores along the lips. You may see sores on the tongue. The tongue may be red and angry looking. So, all of those things are concerning. Menstrual irregularities, delayed healing. We talked about that in terms of pressure ulcers, but in terms of a bug bite on the leg, and then oxygen that doesn't get there to heal, and that bug bite may become bigger and bigger instead of smaller and smaller as it breaks down. We talked about tachycardia and dyspnea and even syncope. All of these things related to a deficient oxygen concentration. We talked about microcytic and hypochromic red blood cells. And finally, if we do an iron level in the serum, we'll find low iron. So what are diagnostic tests? Well, we start with the hemoglobin and hematocrit. And if that's low, we start looking for why it could be low. And we may trial some treatment. A low mean corpuscular volume, and that is the volume of the cell, will be small because it doesn't have that hemoglobin in sufficient quantities. And the mean corpuscular hemoglobin itself may be low. Low serum iron, low serum ferritin, we talked about those. So, as in anything, the treatment is assess and find out what's causing it, and then treat the cause. We'll be supportive of the anemia symptoms until we can find out the cause and treat the cause. Prognosis depends on cause. If it's cancer, the prognosis may be a little different than if it's just a dietary thing. We can give iron-rich foods and iron supplements. If those make a difference, then it's probably just an iron deficiency anemia. We do know that iron supplements can turn the teeth dark, black, brown. And so we try to give this medication around the teeth using a straw if that's possible. I honestly don't know what it tastes like. It may taste great. Um, Now, some sources say to give with food. If there's stomach irritation, if there's hints of nausea, give the medicine with food. It will absorb better on an empty stomach. So, iron supplements, we will continue them. Remember, we have iron stores for 3 or 4 months. So, we're going to take that time and build up our stores. So, we're going to give iron supplements for 6 to 12 months to build up that store of iron. We can give it IM, we can give it IV, we can give it in the liquid, we can increase diet. All of these things are going to help to increase iron. Organ meats have iron. Beef has iron. Beans have iron. Leafy green vegetables have iron. Vitamin C, we do know, enhances absorption. And so it's good to give this medication with vitamin C. Orange juice, for example, would be a great way to give iron supplements. What we do know is that calcium, antacids, those things, milk then, would actually interfere with absorption. So we do not want to give it with those things. Empty stomach, better absorption, but with food if there's irritation or whatnot. And vitamin C is the best thing to give it with. We talked about sipping it through a straw. Now, you do need to tell parents and adults who are taking iron, pregnant women, for example, that it will turn stools black. So that should not be an alarming thing when they see that their stool is very black. Just remember to educate and let them know. We also need to let them know that it can cause constipation, in which case we need to implement a fiber supplement daily for a bit. Okay, pernicious anemia. Pernicious anemia results from lack of intrinsic factor. The stomach wall may atrophy. It, for whatever reason, fails to secrete intrinsic factor. When it does that, then vitamin 12 does not get absorbed. And if vitamin 12 is not absorbed, then red blood cell production falls off. So signs and symptoms, a lot are in the GI tract and the nervous system. And that's important. We may see that smooth, sore tongue, they call it beefy red glossitis, and diarrhea. So there may be some diarrhea here. Sorry, a big yawn there. I apologize. Pale mucosa, confusion, hypoxemia, paresthesia, and this is related to the nervous system. Paresthesias, they may have numbness and tingling in the lower extremities, even sometimes in the hands. Some paresthesias. They may, for the same reason related to the lack of B12, have spinal cord damage. And that may result in difficulty with balance, with gait, proprioception, and we may see some jaundice as well. And this is fatal if it's not treated. So what are the characteristics? Well, this is a megaloblastic anemia. The cells carry less hemoglobin. They have a shorter lifespan. And we also know that granulocyte formation can be affected too. And we may have large hypersegmented neutrophils. So in other words, the neutrophils, the white blood cells, the granulocytes that fight infection may be impaired. It's something to consider. So what's the pathology here? There's decreased intrinsic factor, which leads to decreased absorption of 12, which leads to a deficit of B12, which leads to impaired function of red blood cells, which leads to those big megaloblasts, which are destroyed very early and leads to anemia. How do we manage pernicious anemia? Well, look at the foods here. A lot of foods that include B12. IM vitamin B12 may be a lifelong treatment. We provide for safety in the home. Remember that neural paresthesia, spinal cord difficulties. So we want to look for issues in the home because of gait issues, because of sensation issues, and loss of coordination. Avoid hot and cold excesses. This may mean turning down the temperature in the water heater. This person may run a tub full of steaming hot water and jump in and not feel that it's scalding their skin. The same is true with very cold. They may be working in a freezer or outside and not recognize that they're getting frostbite. We're going to talk about the Shilling urine test, and they need to understand the importance of doing this and what it means and how to do it even. Bland, soft foods until the mouth and the tongue heal. That goes without saying. We wouldn't want sharp things like chips or crackers or tacos or anything like that. And anything with very spicy taste to it. So the Shilling test. The Shilling test tests for pernicious anemia. It's going to tell if this person can absorb vitamin B12. They will fast for 12 hours. They'll get a small dose of radioactive B12 by mouth. Then they'll get a large dose of non-radioactive B12. And that will be given IM. After that, they can't eat. Their fast is over. And they'll collect a 24-hour urine. In 24 hours, we'll check that urine. If very little B12 is excreted, then we repeat the Shilling test, but we add intrinsic factor. If a person has pernicious anemia, they'll excrete more radioactive B12 after the intrinsic factor is given. So if radioactivity is detected in the urine, then we know that we have a diagnosis of pernicious anemia. Pretty neat, huh? All right, folic acid deficiency. This also involves an interruption of DNA synthesis and therefore normal red blood cell maturation. It is caused by an inadequate dietary intake of folate. That may be all the things that are listed here: fruit, green vegetables, liver, poor nutrition in general, malabsorption, drugs, alcohol, drug abuse, anticonvulsants, birth control pills. Any of these can contribute to a folic acid deficiency. Symptoms are similar to B12, but they won't have the nerve dysfunction that paresthesia is. Okay? You may see the cheilosis, glossitis, diarrhea. Diagnosis is going to be made by assessing folic acid. Now, folic acid replacements should occur 1 milligram per day or with dietary intake. Folic acid is not part of a multivitamin, so it has to be taken separately. We know, too, that folic acid plays a part in preventing neural tube defects. See here? And so any female of childbearing age should be taking a folic acid supplement to prevent exactly this. Since we found this information, since we've been giving folic acid, the number of infants born with spina bifida has greatly decreased. But it also makes an important point to include good prenatal care. The last kind of anemia that we're going to talk about is hemolytic anemia. And our exemplar is going to be sickle cell anemia. I call it sickle cell disease because sickle cell anemia is a symptom of the disease. Sickle cell disease is an autosomal recessive disorder. The person with sickle cell has to get this gene from both parents. Each parent gives the child an affected gene. It is incurable. Now, I will tell you that, and then I will tell you that a stem cell or a bone marrow transplant could be curative. But the risk of these far is greater than the benefit right now. So, bone marrow transplants, stem cell transplants are saved for the sickest, most dire cases. Okay, it is predominant in African Americans, but don't let that fool you. I've had blonde-haired, blue-eyed patients who have died from sickle thalassemia. So we don't necessarily know ethnic composition always. be very careful. Um, we do know that it is predominant in African Americans. It's connected to, believe it or not, the trait is connected to protection from malaria, which I found fascinating. Um, it develops by infancy or early childhood, and we're going to talk about that in just a minute when we talk about fetal hemoglobin. The red blood cells develop a sickle shape, and what we want to do is prevent sickle cell crisis. Just a few of the ways of doing that are here, but we're going to talk about those very in depth. So we have types of hemoglobin. We have A, F, and S. A is common, most common adult hemoglobin. Hemoglobin S and all the other sickle hemoglobins comprise some of the abnormal hemoglobins. Hemoglobin F is fetal hemoglobin. Obviously, it's what we have initially, and we have a little of the other. Hemoglobin S is made early on, but we've got primarily fetal hemoglobin, which does not sickle. The issue is it doesn't last long, usually by around 4 months of age or so. The fetal hemoglobin is disappearing, and we're starting to see that taken over with hemoglobin S. Now, normal persons will have hemoglobin A primarily. A person with sickle cell trait, because they have only one gene and not two genes, they will have the trait and not the disease. And they have a small amount of sickling hemoglobin, but generally don't have major problems. In sickle cell disease, however, because both genes are affected, then we have the disease and we have issues with sickling. Compare cells. A normal red blood cell is that donut looking shape that we've been seeing on the slides. It's soft, it's gelatinous, it's squishy, it slides and slips and maneuvers through very small vessels very easily. And they live about 120 days, and we've said that. Sickle cells, on the other hand, and I'll have a picture in just a minute, become sickled. They become hard and very wood-like. And when they do, when they elongate with these spicules inside of them, you can see that they're not going to glide through those small vessels. They're going to hit the sides and stop and block everything else from getting past them. And that's what causes the vaso-occlusive sickle cell crisis. These cells, because they are elongated with these spicules poking at their sides, break very quickly. Hemolysis is that term. And they live less than 30 days. Now here's a normal cell under an electron microscope. I just love to look under the electron microscopes. Here's another picture of a normal, quote, normal red blood cell. You see it's lost its nucleus there, so it's kind of donut. It looks like to me a jelly donut that somebody sucked all of the jelly out of. So here we go. These are red blood cells, but we can see some here that are sickling. Do you see these? And when we look closely, we see these spicules that because of the sickle cell disease, because of the sickle cell gene, these things have crystallized and become elongated. And see how they're poking on those cell walls? Just about to poke through and rupture that cell. So we know that it's a donut shape. We know that it loses its nucleus when it's mature. We know that a mature red blood cell lasts about 120 days. Now, a reticulocyte count. Have you seen reticulocyte on any lab values? A reticulocyte, called a retic, is an immature red blood cell. It's often seen in response to anemia and has a normal value of around 1. I always keep 1 in my brain. A reticulocyte being immature, why do we have immature ones? Well, there's always just a few, that 1%. But in the case of sickle cell and some other anemias, as the cells are being destroyed and there aren't enough of them, the bone marrow reacts. The bone marrow says, oh no, we need more red cells. And it starts pushing out what it's got, which are oftentimes immature cells that aren't quite ready to leave the nest. And these are retics. And we can tell a retic because it's got little granules in it, little bits of nucleus left in there, if you will. It's not quite clean. So they don't work as well as a mature red blood cell. But that's your bone marrow's way to try to compensate and help out and get oxygen carrying blood cells out there. So if the reticulocyte count is very high, what does that tell you? It tells you the bone marrow's working hard. It's working overtime. That's a concern because the bone marrow can tire out and quit. And when the bone marrow quits, it doesn't make red blood cells at all. It doesn't make white blood cells to fight infection at all. It doesn't make platelets to stop bleeding at all. And that's when we have something called aplastic anemia. That can happen to anybody. Anybody can have their bone marrow quit for any reason. In sickle cells, it's a marrow crisis, and their bone marrow shuts down. And so we want to try to keep the bone marrow from ever thinking it has to work that hard. The highest retic count I've seen is in the 30s. That's pretty hard. So these are retics. You see, they almost look like a red blood cell. They've got little bits of nucleus left hanging in there. This right here looks like a white blood cell. So what's the pathology of sickle cell disease? Well, the hemoglobin pigment is abnormal because of the genetic composition. I can't remember exactly. It's the valine replaces glutamine on the 6th position of the beta chain, something like that, but you don't need to know that. So because of this defect, the RBCs are abnormal. This abnormality causes crystallization in the cells. And when these cells crystallize and form these spicules that you looked at on that slide, then they can't get through these small vessels. So we see these crystallizing in the small capillaries. The red blood cells get distorted. The sickle shape takes on. They clog up these vessels. They become like a beaver dam in there and clog it up. Deprive the tissues of oxygen because blood's not getting through. It's extremely painful, this tissue hypoxia. And so the cells rupture, the cells are destroyed, and we have a hemolytic anemia. Signs and symptoms include things like exercise intolerance, anorexia, jaundice sclera. You may see jaundice of the skin. Just think about all these blood cells being destroyed and the body, liver, spleen, whatever, trying to take care of them. Gallstones, same thing. Chronic leg ulcers. Remember, oxygen is not getting where it needs to go. Growth retardation, they may be smaller than their average peer at school. And delayed sexual maturation, decreased fertility. All are results of this vaso occlusion, and it may be repeated insults in that department. Now, I think these are things you need to write down. Highlight them, underline them, put stars by them, whatever you need to do. What precipitates these cells to start to sickle? Because they're not initially sickled. They become sickled. And we can delay that, we can prevent that to some degree by avoiding these things. Dehydration is one of them. Blood gets very viscous, these cells start to sickle. Hypoxia is another one. So we want to avoid high altitudes, hypoventilation, hypothermia. Think about hypoxia. And then think about acidosis and anything that could change the need for oxygen or change the transport of oxygen. Trauma, infections, high fever even, stress. Some people put stress as the 4th one there. Either way. Dehydration, hypoxia, acidosis. Got it? Stress. Dehydration, hypoxia, acidosis cause the sickle hemoglobin to elongate and crystallize. They become very friable, as you saw in the picture. They hemolyze, and we have chronic anemia as a result. The bone marrow says, hey, there's anemia, you need more oxygen. Boom, we have retics. So what did we say about this? It is genetically determined. It is not curable. It is autosomal what? Recessive. And I'm going to talk about hemophilia just a little bit as a comparison for sex-linked or X-linked recessive. Okay, this is autosomal recessive. Both parents have to have the gene. Let's say then that a person has a child with sickle cell. Does that mean their next child will not have it? No, because the probability remains the same. Every child may have sickle cell, or none of them may have sickle cell. These parents may get very lucky, and each parent may only ever give the normal gene to their children, or they may get very unlucky and give the abnormal gene to every child. Okay? But both parents must have the gene in order for their child to have the disease. If a person is a carrier of the disease, they only have one gene, and that's considered sickle cell trait. All of these things are related to what? Dehydration, hypoxia, and acidosis. Right? Everything. So, if we're going to prevent a sickle cell crisis, if we're going to prevent sickling, we have to prevent dehydration, acidosis, hypoxia. This is some of the ways to do that. Drink a lot. I know that you've been taught how to calculate fluid maintenance. These guys need 150% of the average person's fluid maintenance. They need water, and a glass of water every hour. I teach parents to have water by their side constantly, and remind them to drink it. Keep coming back and say, have some water. Avoiding extremes, very hot, very cold. You know, when you jump into a swimming pool for the first time in the spring, how freezing cold it is. They don't need to do that. Moderate exercise is great. Excessive, lots of hydration is a must. Overexertion has to be avoided. Stress has to be avoided. Don't we all need to avoid stress? I'm just saying. And get plenty of rest. Make sure that they're taking folic acid, which may help to make red blood cells, maybe. And regular checkups. And I included props on here. Prophylactic penicillin. We started this study back in the 80s, I think, where we wanted to see if prophylactic penicillin would keep very young children from developing sepsis and infections and be in the hospital frequently with those things and die with overwhelming sepsis. So we started this program, and we randomized patients to either get penicillin or to get a placebo, which happened to be vitamin C. I think it was vitamin C and folic acid, by the way. But that was the placebo, and they were randomized. And then we stopped this study really early because it was discovered very quickly that those patients on penicillin were not coming to the hospital. We're not getting sepsis. We're not getting infections. It was amazing. So the study was stopped, and everybody was put on penicillin. And so to this day, children continue to be placed on penicillin prophylactically, at least until the age of 6. Now, I was going to skip to hemophilia, but I'm going to keep going. Let's just keep going right now. So vaso-occlusive crisis, those are the most common. Think about it. I mean, that's what happens in a crisis. Blood stasis, because of this clogging. They clump in microcirculation, which leads to ischemia, which leads to infarction, which leads to pain, tissue engorgement. Tissue anywhere can be infected. Damage happens to tissues and organs, especially with repeated insult. Any place blood goes, there can be a vaso-occlusive crisis, which is anywhere, right? One of the places that a vaso-occlusive crisis can occur is the brain, and this is a stroke, a cerebral vascular accident. Once a patient has had a cerebral vascular accident, we do everything we can to prevent another one. I mean, if you can imagine a 6-year-old who's had a stroke and is paralyzed for life on his right side, we want to prevent that from happening again. And so they will get chronic blood transfusions to try to keep their sickling hemoglobin level to a minimum by infusing them with healthy red blood cells. What we know happens, however, is that when we do that, we're giving them a whole lot of iron in that blood, and they become iron overloaded very quickly. So then we have to do something called chelation therapy to remove the iron. How do we diagnose sickle cell? We do it by cord blood testing. I believe all the states, except 2 now, and that may be wrong, have newborn screening. Most states have newborn screening. So when you do those newborn blots, you are testing, among other things, for sickle cell disease. Genetic testing. Parents may want to know if they're a carrier. And so that would be a way to test to tell. And then if they are a carrier, if they do have the disease, they need genetic counseling as well, to know what the probabilities are and what they want to do. A sickle cell turbidity test will just look at how many cells are in their sickling. Now, we talked, remember, about fetal hemoglobin. Fetal hemoglobin hangs around until when? 4 months. So guess what? At the end of 4 months, the hemoglobin is slowly being replaced with the hopefully normal hemoglobin, but in a patient with sickle cell, it's being replaced with sickle cell hemoglobin. And so that's when you start to see problems in an infant, somewhere around 4 to 6 months. All right, as always, we're going to monitor a CBC, monitor reticulocyte counts to know how that bone marrow is doing. We may give blood transfusions. We do a careful multi-system assessment. For example, they may be having little mini occlusive crisis in their eyes, so they need a good retinal exam every 6 months. They need a neuro assessment. They need sensory assessment. We need to assess their pain, obviously. Looking at inflammation, sources and signs of infection. Looking for signs of shock. There is a crisis that involves the liver, the spleen, where there's a vaso-occlusive crisis there. Blood goes in to get cleaned up and filtered and put back out, and because there's a crisis, it goes in, it doesn't come out. So there's blood going in from the whole body, and there's nothing coming out. So hypovolemic shock is a result. So definitely something to look for in the patient with sickle cell disease if you're taking care of these guys. Obviously, we talked about hydration, bed rest, conserve energy, avoid dehydration, avoid hypoxia, and avoid acidosis. What can we do? Lots of teaching. They can take folic acid. It may help make red blood cells. The daily penicillin we talked about. Lots of water, definitely. We need to avoid extremes, overexertion, get plenty of rest, regular checkups. We said all of that. There's new research out there that shows that there's a drug called hydroxyurea. They've used it more in adults than children. Can reduce pain events, can reduce hospitalizations, can reduce the need for transfusions. It works just as well as transfusions for preventing stroke. It will raise the hemoglobin level. Problem is, it's a chemotherapy. It can cause malignancies as a result, as all chemotherapy can, and it can cause immune compromise. So right now, it is one of those things that is probably, we worry about the risk versus benefit ratio, and it's not quite there yet for everybody to just get hydroxyurea. There are other promising drugs out there too. St. Jude's is doing a lot of things, looking at drugs and drug combinations. Stem cell transplant, but again, is that risk versus benefit, and these are saved as for last resorts. We're going to encourage screening and genetic counseling for anyone who wants it, for anyone who might be at risk. Um, Again, hypoxia, acidosis, dehydration, avoid them all. Minimize crisis, anything that would lead to impacting any of those things. And then everything during crisis is supportive. Manage the pain, keep them hydrated. All of those things we talked about. We can decrease surgical risk by giving prophylactic penicillin to an adult. We may encourage the screening. Lots of education about the disease. I have families with lots of children, and the moms will come and say, we have 4 kids with sickle cell. I really thought that this one should be normal, right? you know, if you were lucky, yes, but the risk is the same with every pregnancy. So, and then of course discharge planning and getting those guys ready to go home and be safe at home. I wanted to very briefly talk about hemophilia, only because it's a bleeding disorder. It has a different mechanism and um, a different genetic component that I think is important. So we talk about hemarthrosis, which is bleeding into a joint. These are some pretty significant pictures of joints bleeding. You can see how this could cause permanent disability if we leave it untreated and don't do something pretty quick. Hemophilia is the most common inherited bleeding disorder. It is X-linked recessive, and there is an absence of one of those plasma proteins, the clotting factors and the clotting cascade. In hemophilia, factor 8, factor 9 primarily are missing. Factor 8 is the classic hemophilia and makes up about 75% of the cases. Factor 9 is called Christmas disease only because the guy who found it was named Christmas. Von Willebrand's is an abnormality of von Willebrand factor, and maybe a deficiency of factor 8. And it is the one that affects females. Hemophilia typically does not affect females because it is X-linked recessive, and we'll talk about that. The female passes the gene to their sons. It's on an affected X gene. The son gets an X from the mother, and they get a Y from the father. So there's no normal Y to counteract the abnormal X, and therefore the boys are affected. On the other hand, the female offspring may get the affected X from the mother, but they can only get an unaffected X from the father unless he has hemophilia. And so they will be carriers. They can also get the unaffected X from the mother and the unaffected X from the father and be, quote, normal. It's important to know not so much how many, but that all ethnic groups are affected. There is no one spared from the disease of hemophilia. Here's a little bit of the genetics. So the white side, the clear side, is the affected side. Yes, the affected side. Let me be sure I've got that right. So here are the genes. Here's the affected X and the non-affected X. Okay. So the mom can give the affected X. The dad can only give a normal X. So if the dad gives normal X, mom gives normal X, you've got a, quote, normal girl. If mom gives normal X, dad gives Y, which is normal son. I use the word normal very loosely. If the mother gives the affected gene to her daughter, the dad can only give the normal gene, so this girl will be a carrier. If the mother gives the affected gene to her son, the dad gives a Y, so there's no counterbalancing normal gene, and that child will have hemophilia. So you can see how the father can't give their son hemophilia typically. So here is X-linked recessive. This father, in this case, has hemophilia. Here's the affected X. Here's the normal Y. Here's two normal X's. So this mom can only give normal X's. This father can give normal Y's. So all of his sons will be normal. But he can only give abnormal X. And that means that all of his daughters will be carriers. Does that make sense? So women are always carriers. Men have the disease. If that makes sense. I hope it does. Now, some will ask, well, the father could be affected and the mother could have the trait, and potentially they could both give X's to the daughter. That's true, but we don't see those. And that's why I think they must not come to term somehow. Those babies don't survive if that happens. I don't know. We don't see them. So what are the manifestations? Bleeding, right? It's a clotting issue, so we bleed. You saw the pictures of hemarthrosis and bleeding into those joints. Very serious, very painful. And so we want to prevent it up front, and we want to treat it as soon as possible. And we want to get those guys to therapy and get those joints working so they don't become permanently damaged. What else? Hemorrhage, it can be anywhere. It can be spontaneous hemorrhage. Hematuria, intracranial, GI. Intracranial hemorrhage may happen at birth if we didn't suspect that this child already had hemophilia and he came through the birth canal. Chances are there's going to be significant bleeding. Significant bleeding in response to very mild trauma like losing a tooth, picking your nose, any kind of injection, circumcision. If we know a child has hemophilia, they will not go through circumcision for that reason. And then bruising, hematomas, epistaxis, nosebleed, those things. Anything that's bleeding is a manifestation of hemophilia. Abnormally, unusually bleeding. Again, it is not curable. It is not going to be outgrown. There is replacement therapy, which is factor 8 if they have a factor 8 deficiency, factor 9 if they have a factor 9 deficiency. And it is the only thing that really will prevent this clotting. We have to replace the factor. It will cause rapid initiation of clotting. There's human product and there's recombinant product now. Both are still given. DDAVP can stimulate stored factor release. Antifibrinolytics, like Amicar you may have heard of, will keep blood clots from breaking down, make them stay in there a little longer. Supportive care is good. We can elevate, we can put ice, we can immobilize, but it is not going to stop the bleeding. We must have factor replacement in these guys. Obviously, with all of this human blood, each vial of factor 8 may have 10 or 20, I don't even remember. It has a lot of, it comes from a lot of donated units of plasma. And so they're getting exposed to a lot of blood product potentially. So Hep V vaccines. We try to give all the vaccines, especially for viruses that may be in contaminated products. Exercise and diet. Weight could also be a factor in joint bleeds, and so we want to try to keep them as slim and trim as possible and without injury to joints. We will give them exercise that is non-weight bearing primarily. Things like swimming are great for a patient with hemophilia. A new one once who played hockey, he had very mild hemophilia, and before we went out on the hockey court, field, whatever you call it, on the ice, he would give himself factor replacement. And then as soon as it was over, he would give more. And so he played hockey. So, factor replacement. We have these human factor concentrates. with all of this donated plasma. And we have recombinant human factor that is genetically produced. Now, when HIV first started back in the early 80s, when I got out of nursing school, we didn't know what it was to begin with. We were seeing kids that had it and said, "What is this? Looks like cancer, but they don't have cancer." Now we know that we can inactivate uh, products to improve safety. We don't take tainted blood, but we do try to treat all of the donations. These boys can develop antibodies to factor. They may develop an antibody to factor 8 so that it doesn't work anymore. And so then we have to look at getting around that inhibitor and giving other things. And there are other things that we can give. Um, there are the genetically engineered things that may work better. We can give them factor 9, and while they're deficient in factor 8, excess factor 9 helps. And so there are other things that we can do. That's one of the complications of replacement therapy, is developing the antibodies and attacking the clotting factor, the viral infections that can happen, and obviously the joint and muscle and body organs that may be affected if we delay treatment. So it's important they get in there and get treatment in a hurry. Fresh frozen plasma contains all the coagulation factors in the normal amounts. It's free of red blood cells, leukocytes, and platelets, so there's much less risk of reaction. And we can give the fresh frozen plasma for active bleeding or preoperatively. Cryoprecipitate is something else that we can give. It's a concentrated hemostatic collection of these proteins. It's made from whole blood. Cryo is usually frozen and then pulled when we order it. We don't refreeze it. This is what is used as fibrin glue in surgery, if you've ever seen that being used. Fibrin glue will close the wound. All right. Factor 8 and factor 9, powdered, purified from human plasma. It's given for hemophilia and von Willebrand's. Now, all of this calculation, I don't think you need. This is what we try to calculate how much they need based on how low they are and how much they weigh. And so we try to calculate what they need. It has a low half-life, 8 to 12 hours, which means every 8 to 12 hours they're going to have to get another dose. And they'll do that for a while until we're sure they've stopped bleeding. And then we'll continue a little longer. We may teach them how to do it at home. There we go. So, what are your principles of management? Don't make them bleed. Do everything we can to stop bleeding, to be supportive, and to avoid the permanent joint issues. No contact sports, no sharp toys, wear padded clothes, maybe a helmet. Don't let them pick their nose. Hard to do when you're a child, right? Supportive care. Remember, rest, ice, compression, and elevation may or will not control this. It may slow it down until we can get replacement therapy. We've got to have replacement therapy. Suturing and cauterization. Why would that be a problem? You're just making more holes and more injuries to bleed. So we avoid suturing and cauterization if at all possible. IM injections. We don't want to give anything into that muscle that might bleed. We'll give it sub-Q or we'll find another way. Aspirin keeps those platelets from being sticky, is what I always say. So we don't give aspirin. And then we do what we can to avoid the permanent joint problems. And we talked about that. Now, prior to being heat treated, most of our patients were exposed to hepatitis B. HIV came along. And before 1985, they were all HIV positive. Those patients all died of HIV very early on in the epidemic, I guess. Without HIV, without hepatitis, their life expectancy is that of the general population. So I think I'm done here. I'm going to go and do another presentation with the questions. And so these will both be posted for you. Thanks so much for listening.